Hi everyone, እንኳን ደህና መጣችሁ። የመጀመሪያ ሰዓታችን በ5 ደቂቃ ትንሽ አልፈናል፣ ግን የተመዘገበው ሰው 290 አካባቢ ነውና ተጨማሪ 5 ደቂቃ ብንጠብቃቸው ፕሮፌሰር አለህ አይደል?
አለው ይሰማል ድምጽ?
አዎ ይሰማል። ብዙ ሰው ስለተመዘገበ ትንሽ ደቂቃዎች ብንጠብቃቸው ጥሩ ነው ብዬ ነው።
እሺ እሺ
እንጀምር መሰለኝ for the interest of time ፕሮፌሰርን ኢንትሮዲውስ እስካደርግ ይገባል ብዬ አስባለሁ። ፕሮፍ ልጀምር አይደል? 45 ሰው ይላል።
እሺ
So welcome everyone. የዛሬው ሴሽን የተዘጋጀው በኢትዮጵያ ሜዲካል አሶሲዬሽን ስፔሲፊካሊ የሜዲካል ኬር ኮሚቴው ነው። ሆስት የተከታታይ ሁለት እርግጠኛ ነኝ ኢንጆይ እንደምታደርጓቸው። So I would like to introduce Professor Merkuze. I'm really honored to introduce Professor Merkuze. He's a well-published health researcher. He has published a lot of research on health policy and system, and he has been a researcher and educator for the past more than 16 years actually. He has an immense experience in health policy and system research, evidence generation and translation ይቅርታ ጠይቃለሁ። He has an immense experience in system research, evidence generation and translation, and currently he is a deputy director for evidence to policy for the PENET project of Harvard University and the University of
ዶክተር እስከዳር አለሽ ወይስ ወጣምስ?
ቱርክ I'm sorry, I apologize አደርጋለሁ. So currently Professor Merkuze, he's a deputy director for evidence to policy for the PENET project group of Harvard University and the University of British Columbia. He's also working as a senior research advisor at Ministry of Health, and he is the chief editor of Ethiopian Medical Journal. So I'm very glad he's willing to share his experience with us. Professor Merkuze.
Thank you, Dr. Skadar. Thank you for your kind introduction. አንድ ሰው ቢመልስልኝ ደስ ይለኛል። ይሰማል? Thank you. So today we will be talking about evidence-based medicine research using context. So these are the objectives I would like to attain at the end of. I would like you to be able to describe the concept of evidence-based medicine or evidence-based practice, formulate an answerable clinical question to be able to use evidence in your work, in your clinical work, and search relevant evidence to answer your clinical questions, critically appraise the evidence that you have identified during your search, and finally, use evidence to inform your work in your clinical activities. So, as usual, I will begin by, just having one of the definitions. There are several definitions in the literature about evidence-based medicine. So one of those is, the one you can see on the slides. So evidence-based medicine is the conscious, explicit, and judicious and reasonable use of modern best available evidence in making decisions in relation to your patients. So you can see the keywords here are conscious and explicit use of evidence while making decision. As you can clearly see in this definition, so evidence is the main, probably it seems the only basis for making the decision in relation to your patient. But in reality, it's not true that we do make decisions in relation to caring to our patients just based on evidence. There are other issues that we consider. So that's why we have some other considerations about making decisions using evidence in patient care. So before we talk about a modified definition of evidence-based medicine or evidence-based practice, let's say a few words about the history of evidence-based medicine itself. So historically, it's in 1972, a British epidemiologist witnessed that, clinicians are usually not following the latest evidence, not making the decisions based on the latest evidence in taking care of patients. It's not because the clinicians didn't want to do that. It's because there was no mechanism to systematically review clinical evidence about a particular issue. For example, if you are taking care of a patient with leukemia, then a number of evidence in relation to treating leukemia might be out there. So a number of publications in different journals. So clinicians had no mechanism to pull those evidences together and inform their clinical practice. So it was more of based on ad hoc selection of scientific literature. So if you access a publication that I have published, then you just use that one. So you will not be able to, access the others. So there should be a mechanism, according to R.K. Cochrane, this epidemiologist. There was a need to really have a system to pull evidence, relevant evidence for patient care together. So he made this suggestion back in 1972. Then in 1980s, Ian Chalmers, suggested the idea of doing systematic review of randomized clinical trials, so that to help the obstetricians during that time to be able to access a pooled evidence to inform their clinical practice. And then in 1990s, this practice of doing systematic review became more and more famous. And the Cochrane systematic review, the Cochrane library, which you might be familiar with, came into existence. After that, the Campbell collaboration, the JBI Institute of Evidence-Based Healthcare, and others, came into being. So these days, having systematic reviews to inform clinical evidence is, more common than it was in the 90s. So I told you that, it's not true to say that clinicians make decision only based on evidence. So what do they use to, to inform their decision in making decision related to their patients? Not only best research evidence, but also clinical expertise, which they have gained through experience, and also patients' values and preferences. So patients' values and preferences are also used to inform. So people call this the evidence-based medicine triad. So taking all these three dimensions into consideration, evidence-based can be redefined as a systematic approach to clinical problem solving, which allows you to integrate the best available research evidence with clinical experts and patient preference. Then it becomes, in actual sense, not evidence-based, rather evidence-informed decision. So evidence would make up just a component of the requirements for making the decision. So it will be supplemented by the patient's preference and, of course, the experience of the clinicians. That's what you actually do. So this would be a more pragmatic definition of evidence-based medicine, or as people now prefer to call it, evidence-informed medicine or clinical practice. So these are, you might have other further considerations, not only, values of the patient and preferences and concerns of the patient, expectation of the patient, but also, what is available in the health system also affects your decision. For example, even though you are aware of, the best medication for a certain condition which a patient is having, you might not be able to prescribe that intervention because it's not available in your setting, in your local context. So what the health system offers, what the health system could offer, would also affect whether you make a decision about using a particular intervention to your patient or not. So, of course, your knowledge, skill, attitude as a doctor, as a clinician would count. The best research evidence would count, but also what the health system can offer would also be a very important consideration. Other is concern about litigation. Although it might not be very common in our setting, about litigation also, somehow modifies the decision of clinicians. Sometimes, it could be investigation for your patient, or could be treatment intervention. Your decision might be, altered because of your concern about litigation. Sometimes you might order a particular intervention just to avoid, accountability. So we can clearly see that the components of clinical decision making are more complex than we see. So it's not only evidence, but also the other components need to be considered. So why has evidence-based practice emerged is the question. When I talked about the history, I have mentioned that R.K. Cochrane noticed that, people are using ad hoc selection of evidence from research to inform practice. So why did that happen? It is because, there are gap between what is being practiced and what is found in research. So professionals tend to rely on knowledge gained during primary training, during medical school training. People might also have, prejudice and opinions about, whatever intervention is available out there, and the outcome of previous cases also determines your decision, doesn't it? Because if you from your experience, if you feel that the outcome of a particular intervention is not favorable to the patient, you tend to ignore it. Although the research evidence out there says, in the contrary. And fads and fashions are followed sometimes. Advice of seniors and not so senior colleagues might also inform practice. So there is a no-do gap. There is much no-do gap in clinical practice. So there is a need for evidence-informed practice in clinics. So we need to mind the gap. That's one of the reasons. The second reason is poor quality of much of research. You know, even though you might access some research to inform your practice, there is a need to assess the quality of the research evidence that you have accessed. Why do we say so? Because, you know, it's not a guarantee that when a paper is published to a particular journal, it is, you know, then the best available evidence. It's not true, because even though a paper gets an evidence gets published in, let's say, on the Lancet, you might, at the end of the day, you know, if you do appropriate critical appraisal, you might learn that there are methodological flaws within the paper, and you know, the sample size and everything might not sometimes appropriate to your setting, or to infer the findings to your setting. And most importantly, there is information overload. This is what we mentioned earlier. So if there is information overload, if there are, you know, multiple publications on a particular subject from different journals, from different researchers, then you know, as a clinician, you would be too busy to really pull the evidence together and, you know, synthesize the best available evidence to inform your practice. So these are the most important reasons for having evidence-based practice in play. Okay, so research practice gap, poor quality of much of the research available out there, and information overload. Let's give, you know, just an example. On PubMed, if you open your browser on PubMed, you would read that there are, just on PubMed, you know, just on PubMed, there are 34 million citations for biomedical literature from Medline, okay, on life science journals and online books, you know. So how would it be possible for an individual to really go through every publication, millions of citations, to really inform his or her practice? That would be impossible, right? So there is so much evidence, but too little time for you as a clinician. One report states that a total of 20,000 trials were published each year. You know, this report was back in 2005. So with more than 400,000 trials in total. So it's not easy to cope up with, you know, the dearth of publications that comes out every day. For example, in 2005, approximately 55 new trials were published every day. So if you, as a general practitioner, if you want to keep up to date yourself in terms of, you know, what these 55 new trials bring out, then you would have to read more than one study report every half hour, day and night. No sleep, no other things to do, see? So it's not possible to really cope up with for clinicians with the amount of evidence being generated every day. So in addition to the RCTs, randomized controlled trials, in 2005 alone, 1,800 papers were also indexed daily on Medline, from a total of probably 5,000 journal articles published each day. So this is, you know, we can see much, like overwhelming amount of evidence coming out, and difficult to cope up with it. The second reason we have mentioned is, poor quality of evidence. Although there are, a lot of publications coming out every day, the quality, particularly the methodological quality of the research evidence being produced, is not always optimal. So there is a need to consider whether, a finding is of high quality in terms of methodology, whether it is internally valid. And there's also a need for consideration of whether it is clinically relevant. Something since research might show that there is statistical significance, but is it clinically relevant or important? Is it clinically significant? So there is a need to do some quality check before you decide whether to use a particular evidence to inform your practice in your clinic. So let's see a couple of case studies. Probably we might look at the first one to try to understand how helpful evidence-based medicine is. You can put your reflections in the chat box. Otherwise, you can also raise your hand as appropriate. So let me project the case study. So this is one of the case studies, and just take 5 minutes to read through it. Then you'll reflect how important was evidence-informed practice in this particular scenario. So I will give you 5 minutes. So you can put in your comments in the chat box, or you might choose to raise your hands and participate. So the question is, how helpful or how important was evidence in this particular case? Good. So time is up. I think I have a hand raised. Dr. Tadla Gebrezadiq, you may reflect. How important was evidence in this particular case? Yes, I can see in the chat box, it helps the physician to consider other differential, which he initially didn't consider. Very important, it created change in diagnosis and treatment. All possible differentials have been considered because of the evidence. Yeah, so you are right. These are, this is just one case. You might encounter even a more complicated case in some circumstances. So it's good to turn to evidence rather than just rely on consultation or your own experience. So another very short case study. Please read through this one again. Would help us better understand how important evidence is in your practice. Yeah, it's not always the commonest reasons. It's better to consider the rare one, but that would happen. The rare ones might not come to mind very easily, so it's always good to consult the evidence. So another interesting case study where a dog bite is involved. So how about this one? In this case, again, informing the patient appropriately would need a more concrete evidence than, you might tell the patient right away, your opinion. Of course, your opinion is also based on your knowledge of your subject area. But again, sometimes you might need to cite concrete evidence. In this case, you can tell the patient for every 100 people with dog bite, treatment with antibiotic will save 7 from becoming infected. That means treating 14 people with dog bite will prevent 1 infection. So this will help you to frame the information that you tell the patient in a very clear way and understandable to a lay person. So yes, where I can see a very good example of use of evidence and patient preference. Great, thank you, Dr. Yosef. For any bite, we should give prophylactic antibiotics. Yes, but patients might be hesitant in receiving that one. But again, to convince the patients, then we need evidence. That's the message from our case studies. So let's move on to the steps. So evidence-based medicine, yes, it's important, as we can see. It really informs our activity. Of course, it's not the only thing to base on your decision in clinical settings. You need to consider other issues. We have already understood that. But how do you do evidence-based decision in relation to your patient? The first thing you need to do, as you can see on this slide, is to ask an appropriate question. So you need to formulate an answerable question, a question that could be answered by research. Then you have to acquire the literature to help you look for the answer to your question. Then appraise the evidence. We have said that there is a concern about the quality of evidence that's available out there. So there is a need to do a thorough appraisal, whether the evidence is valid. When we say valid, is it internally valid? Meaning, is the methodology of the study to generate the evidence valid? That's the first question. Then, is it applicable to our setting? Meaning, is it externally valid? Is it something that could be generalized to what we do? And the fourth step being applied, just test it. So you have got the evidence, you just test it, and finally you need to assess whether you need to assess what happened after the application of your intervention, or after. Let's look at each of the steps with a bit of detail. So the first thing we do is to formulate an answerable question. And for this, we need to apply the PICO principle. I hope many of you are aware about this simple approach to framing questions. So the first P stands for population or clinical problem. It could be population or problem. This shows who are the relevant people or group of people that are being affected by that particular issue. So population is the first P. Then intervention or indicator could be also index. When it is intervention, it might refer to a procedure. It could be a treatment, surgical or medical treatment, could be a dietary intervention. So an intervention to treat or prevent could be to prevent also a condition. And I might also stand for indicator, in which case it refers to an environmental, chemical, or hazard, or physical feature, or a factor that might affect a health outcome. And it could also refer to index, in which case we are concerned about diagnostic tests. Okay, so it could be a blood test or brain scan, which we refer as a measure of success or appropriateness. C stands for comparator. This is the one, the population. You have the intervention or the indicator or the index, which is being applied on the population. So when you have a comparator, it is a group without the intervention or the index being applied to. So this shows an alternative or control strategy, exposure, or test for the comparison of interest. And finally, is outcome, very important. This shows what is the most important concern for you in terms of asking that particular question. So what do you want to make happen, or what do you want to stop happening? So these are the possibilities. And it could also be the case we might refer to the patient's concern. Okay, patient preference, patient comfort, and other things might be the outcome measuring. So whatever question, whatever clinical question you might have, you can frame it this way. But remember, it's not a must that you need all of these components in each of your questions. But there would not be any question without P and O. You might not have the comparator, you might not have intervention in some cases, but O and P would be always there. So you have a population and there is an outcome of concern in your circumstances. What would impact whether these all four components are available or not? It's affected by the type of question that you frame. So let's see the type of question on this table. There are several types of questions that you might be interested in. So this table tries to show the type of questions you might frame. So a question might be more of interventional in nature. So what should I do about this condition, for example? So what should I do to treat, let's say, asthma? So it could be about an intervention. So it's by far the most common clinical question that you might be concerned with. So when there are interventional questions, we usually try to compare the intervention with doing nothing, or with a placebo, or another existing intervention. So it's highly likely that we will have all components of PICO in interventional questions. So let's say, what's the effectiveness of using, let's say, a certain drug A in treating asthma as compared to B among elderly patients? So we have all the 4 components in this question. The P being the elderly patients, the I being drug A, the comparator drug B, those who are receiving drug B, and the condition being patients with asthma. So you might also ask questions about etiology, what causes a problem. You might ask questions about diagnosis. So in this case, you would have an index, diagnostic index. So you might ask prognosis questions. You might also ask epidemiological questions. So how frequently a condition happens in a particular population. So what is the prevalence of birth defects among mothers who smoke? So this might be the question. So in this case, there is an epidemiological question where you have the population, the outcome, of course, which is birth defects, and you also have the intervention or the exposure, in which case it's but there is no comparator. So it's not a must that we need the middle 2 components, but we usually need the P and O. Without P and O, there would be no question at all. So let's see an example, written example for PICO. So a client has come to your clinic to discuss the possibility of getting a vasectomy. He says he has heard something about vasectomy causing an increase in testicular cancer later in life. You know that the risk of this is very low, but want to give him a more precise answer. How would you frame your question? To guide your search from the web, let's say. So anybody willing to frame the question and put it in the chat box? How would you frame the question? So the patient has a concern, which is testicular cancer following vasectomy, but it is low, but you would like to make it more concrete, based on evidence and compelling. How would you frame the question first? You may put your question on the chat box. So we have 2 minutes for this exercise. In 2 minutes, just frame the question. Then we will talk about the PICO. Good. We have, I think, a couple of responses. Is vasectomy a risk factor for developing testicular cancer? Okay, excellent. The prevalence and the outcome of vasectomy. Is vasectomy a risk of testicular cancer? Okay. Yeah. What is the likelihood of developing testicular cancer as compared to those who do not have testicular vasectomy to develop testicular CA. So prevalence of testicular cancer in vasectomy. Yeah, so you would like to know the answer to the question, what is the proportion of patients or clients developing testicular cancer following vasectomy later in life? So this is the question. So who are the population? Adults. So among adults, the intervention is vasectomy. The comparator is no vasectomy, and outcome being testicular cancer. So you have framed the question very well. You would see the importance of framing your question this way and breaking it down into the PICO components is a critical step in doing appropriate search in the web. If you want to do a proper systematic search, then you would need to properly frame your questions this way, and of course break it into the components, the PICOs that we have just done later. And once you have framed your question this way, if you the next step is tracking down the best evidence. Do proper search. Do proper search. Where do we do search? መቼም ዛሬ we don't go to hard copy መጽሐፍ ምናምን ፍለጋ አይሄድም ብዙ ሰው, because there are a lot of electronic databases which we can rely on to look for evidence, best available evidence, up-to-date evidence. So these are the major databases you might go to, particularly to look for published, peer-reviewed articles. So PubMed, which I mentioned earlier, has got 34 million citations, probably the biggest database where you can find biomedical literatures. Then you have Embase. PubMed, by the way, is not based on the subscription basis, so there is no need to pay for it. So but Embase is based on subscription. You need institutional or individual subscription to use it, and it's mainly for systematic reviews, of course, as compared to PubMed. Of course, it has also other primary studies in it. Cochrane database of I'm sorry, I think my internet was interrupted. So these are the databases Embase based on subscription, Cochrane database of systematic reviews, initially meant for just randomized controlled trials, systematic review of randomized controlled trials, but these days also contains systematic review of observational studies, guidelines, and qualitative studies even. CINHAL, more of social, behavioral, and nursing literature. Scopus, systematic review of all sorts in other articles. So you can go to any of these to look for published literatures. Of course, evidence is not always confined to published literature. It might be also available. The best evidence might be available in unpublished sources. We call these sources gray literature. So Google Scholar is a very good source of gray literature. Institutional repositories, repositories of, for example, Addis Ababa University or other universities could be a good source. people put their dissertations and research which are not published, but might have valuable evidence for informing your decision as a clinician. And clinical trial registries, drug registries, organizational websites such as website of WHO, the website of UNICEF, website of OECD, and others, could be used as a source. Or they might have guidelines and others posted on the website. Government websites in some circumstances, particularly websites of the Ministry of Health, for example, in our case, might be used for looking for the literature to answer your question, your clinical question. In raising your question and doing the search, we have said formulating your question in PICO format is a critical step. The next critical step is to determine the use of Boolean operators, the use of and, or, and not on your search process. So if you use or, then you are saying, let's say, if you say testicular cancer or vasectomy, then you would find all papers mentioning both testicular cancer and vasectomy. So, it will be very broad. So when you connect the search terms with or, this will be a very broad search. When you connect by and, it will be only the intersection. So if you say vasectomy and testicular cancer, then you would access only literatures mentioning both words at the same time. So it would be narrower. And if you are not interested in a certain segment of the evidence, let's say, if you want to state testicular cancer, not vasectomy. So you would find papers mentioning testicular cancer, but not in relation to vasectomy. So this will be it will cut out some of the evidence which is not of your interest. So this is how we need to use the operators. Let's just do a quick search on PubMed on our PICO, on our earlier PICO. Let me share on my screen, my browser, and we will do a quick search just to show you how important these Boolean operators are. So PubMed, you can go to PubMed. Then, so it's good to use. You can paste, you can write down the terms here, but I would prefer for you to use the advanced feature where you can appropriately formulate your question using the Boolean operators. So the previous question, our P was adults. So let's write male adults. So you just click add, it will put it in the query box. Then male adults. So it should be and, because we have to find literatures mentioning. It's a must that it mentions male adults. It should be in male adults. So vasectomy. Let's go to the intervention. Vasectomy. I don't know if the spelling is correct. Yeah. So and you see, and again, is there any other name for vasectomy? We can include it with our search. Anyone who could put in an alternative word for vasectomy, you can include it. Otherwise, let's move on to, so we have the population, the intervention, then the comparator is no vasectomy, we don't need it here. Then outcome is testicular cancer. Testicular cancer. So it's again end, but testicular cancer might also I think this is not testicular cancer. And testicular cancer might be stated in the literature as testicular CA2, right? So it should be with or, because this is just an alternative. So you can do the search, you know. So yes, so we have about 3,330 searches. So you can, if you want, you can limit or you can do a filter. So you might say, I am interested only on meta-analysis or randomized clinical trials. So it will give you, you know, the number would automatically decrease when you do these limits. You see, only 70 results are available if you are interested only on clinical trials. Or if you say, I am interested in meta-analysis, then you click just meta-analysis. So there are only 25 meta-analyses mentioning male adults, vasectomy, and testicular cancer. So you can also limit your search by, you know, whether it is full text or not. You can search by year, you know. I want just the most recent one, just the studies in the last 5 years. So only 11 studies. So this is how we simplify our search when we use the PICO format in doing systematic search for evidence in clinical evidence-based medicine. So now we have formulated our question, done appropriate search, and came up with, you know, several literature. So let's say our final search came up with 11 articles. So would those articles be, you know, right away useful to our purpose? No, that's not true. We need to critically appraise the evidence. So what do we mean by that? We need to do critical appraisal, systematic evaluation of the papers. What questions could we ask? These are, you know, the most important 4 questions. There are, you know, a number of tools to conduct critical appraisal of published literature. But these are, you know, the basic questions we ask, you know, in any of the tools. The first one being, does this study address a clearly focused question? You know, if in a particular study, if the question is not stated clearly, you know, if you are not able to break it into the PICO formats, it's not necessary that they put it in PICO format, but if you cannot easily break it into the PICO format, then the question is not very clear. So the first question we ask is the question stated clearly? You know, if short of, you know, clear questions, then the commander of the study is in problem, because the questions command the entire process of the study. So is it clearly focused and clearly stated? The first question. The next one is, did the study use valid method to address the question? You know, not all questions possibly be addressed with the same design or with the same methodological approach. So there are different approaches to address different questions. So the type of methods that we use depends on the type of question that we have posed. So depending on that, we do critical appraisal of the method. And we have tools, as I said, for each design. We have tools for randomized control trials, for cohort studies, or observational studies. We have critical appraisal tools for systematic reviews. We have critical appraisal tools, for all sorts of, even for qualitative studies. So methodological quality check is the next thing we do. The third are the valid results. I'm sorry, I'm again, I hope I was on this slide. So did the study have valid methodology is the next question. The third one, whether it is clinically important. Is it important or relevant to the patient group which you are interested in? And finally, are these valid or important studies, clinically valid or clinically applicable findings in the study? Are they, applicable to the specific patient group that you are interested in? These are, some sources for critical appraisal. There are different tools, as I mentioned earlier. For example, one of them, most famous one, is Critical Appraisal Skills Program Checklist. They have the checklist for all designs, for observational, interventional, systematic reviews, and qualitative studies. So we can use that one if you want. Just if you click this link, then it will take you to the tools. For example, if you are interested in cohort studies, then you have a specific tool to do that. By the way, it's just a couple of pages. It's not a very, very complicated tool. You can download and look at it. There are other sources also, the Joanna Brixton Institute, the BMJ best practice, all other sources could equally be used. This is the traditional hierarchy for questions related to effectiveness. If you are particularly looking at randomized controlled trials, this is that. So where do you find the best evidence? It is from, particularly in clinical settings, it is from randomized controlled trials, particularly systematic review of randomized controlled trials is the highest level of quality. Then you have individual randomized controlled trials, then observational studies, case control, then case series, which is, some more or less an experience of a patient or a few patients. But this traditional hierarchy might not be true in cases of some questions. When the question is effectiveness, this is the best approach to evaluating the quality of evidence. But if you are asking the why questions and the how questions, then this triangle might not be valid, meaning qualitative evidence might be the most appropriate to answer this question. For example, why do patients fail to adhere to their medications? This is a complex question which would demand a qualitative study to answer the question based on the perception, attitude, and experiences of the patients. And so it won't be appropriate, to say randomized controlled trial would be the best source of evidence for questions like this one. በጣም ይቅርታ ኮኔክሽን ተቋርጦ ነው። I'm almost done. So yeah, so in the earlier slide we were trying to state that it's very important to critically appraise. Once you appraise it, once you have made a decision that this is of good quality and relevant to your setting, then you apply it. So is the treatment or test feasible in my setting? Is the first question you ask yourself when in terms of applying. Then what else do I need to apply this evidence? Do I need additional resources? Do I need additional training or skill building before I try to apply it? Do I need to do anything about with the patient before introducing that particular intervention? What alternatives are there? Is it the only option or is it the best one? That has to be. And how about the patient? Is my patient so different to those in the study subjects? The sample from which the conclusion in the study has been based on might not be the same as the group of patients you are treating or you are interested in. Will the potential benefits of the treatment outweigh the potential harms of the treatment for my patient, specific to your patient? So that would be a very important question. And finally, what does my patient think about it? Because we have said evidence-informed decision-making in terms of taking care of your patient is not only or solely based on evidence, it's also informed by the values, concerns, and preference of the patient, and of course your experience as a clinician. So that's all from my side. Any questions, any comments are welcome. You can raise hands, or you might also put your questions on the chat box. Yeah. Thank you. Dr. Skadar, over to you. Do we have a Dr. Skadar here? So, Dr. Takala, please proceed and forward your question. You have to unmute yourself. Mute no, Dr. Takala. You have to unmute.
Unmute, okay. Setting like us, we got this good chance because we are in remote areas. So such chance is very low. So how we can apply evidence-based medicine like Ethiopia in a poor setting like Ethiopia?
Thank you so much, Dr. Takala. Any other? Okay, we have also a question in the chat box. አሁን አይሰማም እንዴ? አይሰማኝም የሚል ነገር ነው ያየሁት። I hope people are hearing my side. So any other question? Okay. Yihalam, please unmute yourself and raise your question. Dr. Yihalam. Dr. Yihalam. Okay, any other question? Okay, just ሌሎቻችሁ እያሰባችሁ, yeah, but resource is always a constraint. We know that it's a very clear obstacle in terms of providing optimal care to our patients. But not everything we find, it's not always true that yes, resources are always obstacle to providing optimal care for patients. but ይሰማል የኔ ድምፅ? በጣም ይቅርታ ኮኔክሽን ወጥቶ ነበረ። ዶክተር እስከዳር ተመልሳለች?
Recording in progress.
ዶክተር እስከዳር አልተመለሰችም። ኦኬ ሶ የቀደሙን ጥያቄ ለማንሳት resources are always in scarcity, so it is a problem for us to provide optimal care. Resources might be the issue, but let's remember that using best available evidence would not in all circumstances require more resources, so the best thing is to inform ourselves with the best available evidence, then check whether we have the amenities, the facilities to execute that particular intervention or that particular evidence. So yeah, resources are scarce, but we can still use the best available evidence. Another question, is it acceptable to apply recommendations from super quality research findings into real clinical setting, provided that the recommendations are not in standard guideline? Yes, I would say yes, as long as, particularly if it is not a single study. If you have an evidence from a systematic review of, for example, a randomized controlled trial, and if that randomized control trials included in the systematic reviews are of good quality, then it would be appropriate. We don't expect ourselves to keep on doing the wrong thing while we know it's harming the patient until the guideline is prepared. Yes, we need standard guidelines, but until the standard guidelines arrive, we have to inform ourselves with the best available evidence. Yeah, so any other question? By the way, these days, guidelines are also informed mainly by systematic reviews, if they are available, because we have said these are the highest level of quality, particularly for clinical issues. Randomized control trials are included in the systematic reviews, and that would be informing the guidelines themselves. But until a guideline comes out, we need to use the best available evidence, which we have appraised. It should be of good quality, and usually we better use systematic reviews, because systematic reviews try to pull the evidence from several studies, not based on just a single study. So we don't change practice based on a single study, but based on multitude of evidence pulled together. Dr. Yiheno, please unmute yourself and pose your question.
Okay, thank you, Professor. My question is on usually systematic review and meta-analysis are in confusion for me. So what is the difference between the two? And the other.
Okay, continue, please.
And the other question is the difference between critical appraisal and critical review. What is the difference? This is my question. Thank you.
Thank you. Thank you. So, yeah. So let's start with the first question. The first question: what's the difference between meta-analysis and systematic reviews? You know, systematic review is, of course, an umbrella word for a systematically pooled evidence. So what do systematic reviews try to do? They try to pool evidence available in multiple studies, multiple primary studies, single studies, and the purpose is to increase the sample size, to increase the power of the conclusion. So people use systematic review, meta-analysis, meta-synthesis, narrative synthesis. These are, jargons used in this field. And the systematic review is an umbrella word, which implies there is a systematic search to inform the review, while meta-analysis is quantitative meta-synthesis. This is like meta-analysis is a systematic review which pulls quantitative evidence together. Definition here. So you bring quantitative evidence together using meta-synthesis. When you say meta-analysis, when you say meta-synthesis, you bring qualitative evidence together using meta-synthesis. So meta-synthesis is for qualitative studies, and meta-analysis is for qualitative studies. So in meta-analysis, you have effect size, relative risk, odds ratio, and things like that. While in meta-synthesis, it is just text. So it is a qualitative study. So systematic review is an umbrella word for both. There are also other terms, scoping review. While the scoping review, you don't do quality check for the included studies in scoping review, for example. But in all other systematic reviews, you need to systematically search, identify the articles to be included, then do quality check, methodological quality, then pull the evidence, okay, in all cases. But in meta-synthesis, you include quantitative studies, and in meta-synthesis, qualitative studies. And remember, you might combine both together. So people usually say, state the title, then say meta-synthesis and meta-analysis. So it's not wrong to state that way. I hope that's clear. Critical appraisal and critical, I think these are just synonyms, and the more formal term being critical appraisal. And critical appraisal is a systematic evaluation of the methods in a particular published study. So your purpose is to check the quality of the approach to answering the question. I hope that answers your question. Okay. Another question we have here is the setting that the study was done, even if the evidence is from randomized trial, along with acceptable, feasible, and cost is important. Yes. Let's say there is a recommendation based on different systematic reviews and randomized control trials about a particular intervention, and that intervention has been approved by the World Health Organization. It has been recommended. Is it something useful, applicable to your setting right away? And that might not be the case. So we need to do feasibility, acceptability check in terms of cost. You might not have the technology to introduce that particular intervention. You might not have the human resources. It might be against the values and preferences of your patients. So there are several considerations apart from the evidence that you acquire through your search. There are several considerations you need to do to make sure that you are practicing evidence-informed medicine. We have said there are differences between evidence-based. When we say evidence-based, it is just solely dependent on the evidence. But we have said that there are health system considerations, there are patient-related considerations, there are capacity-related considerations, and there are also experience-related considerations we need to bring into the picture, not just the evidence. So you are right. We need to check for feasibility, acceptability, cost, and everything else before we use a particular evidence. Good. So I think there are no more questions. So if Dr. Skadar, if you are able to say anything, I think we are done. I have addressed a few.
Thank you, Prof. Hello.
Dr. Skadar?
We can hear you.
Sorry. What any question? Good. So thank you. I think if there are no questions, I'm done. Thank you for your appreciations. That's it. If there are no any questions, Dr. Skadar, over to you if you are around. Okay. So Dr. Skadar is not connected anymore. So thank you very much, all of you, for attending our webinar today. So thank you.